Good evening. Good evening, sir.
Good evening, Dr. Surendranath. Bagunara?
Yes, sir. Yes.
5 minutes on ka undi kada.
వాస్తవ మురళి రావాలి కదా సార్.
వాళ్ళు ఇంకా మన బిల్డ్ రాలేదు కదా ఇంకా. Ravi Kumar has joined, I think. I later.
Good evening, Ravi.
Good evening. Good evening.
Ravi, బాగున్నావా?
Actually, ఆ పనిలో ఉన్నా.
దాంట్లో ఏముంది?
కూర్చో. Oh, so nice of you. Yeah, good evening, Jagdish bhai.
Good evening. చూడటానికి ఆరెంజ్ జ్యూస్ లాగా ఉంది, దాంట్లో ఏముంది అంటున్నా.
No. I am with the friends. But it is nice to see Surender, Jagdish. I don't know somebody else. One more person is the doctor. Hello?
Open. Video is not open.
Only 3 members కదా, అందుకోసం పర్వాలేదు.
లేదు, ఇంకో ఆయన ఉన్నట్టున్నాడు, ఆయన వచ్చాడు. దాన్ని
ఇక్కడ జగదీష్ చంద్ర కోపం వస్తుండొచ్చు.
నాకెంత కోపం.
I'm enjoying Jagdish.
Have your fun. Have fun. Great.
Tomorrow I am going to Haryana.
Haryana na? Rohtak?
Delhi.
Last week I was there in Delhi.
Yeah, our friends are there, no? You know Mahavir.
Mahavir Jain.
Yeah.
ఏమందరా గోతక్లో ఏమందరా?
ఏం లేదు, జస్ట్ లైక్ దట్. ఏమైనా ఫంక్షన్ ఉంటే పోతాం. ఇప్పుడు సురేందర్ ఇస్ ముంబై, ఐఎమ్ ఢిల్లీ.
అట్లా ఏం లేదు. నథింగ్ లైక్ దట్. సురేష్
నేను జాయిన్
సార్.
స్పీకర్స్ హావ్ టు జాయిన్, ఐ థింక్.
సార్ చెప్పండి.
సురేష్ బ్యాక్గ్రౌండ్ గోవా పెట్టుకుంటాడేంటి?
చలికాలమైన ఇక అదే సార్ బ్యాక్గ్రౌండ్.
బ్యాక్గ్రౌండ్ గోవాలో పెట్టేసుకొని అట్లీస్ట్ అంటే అది
వెళ్ళలేకపోయినా కనీసం బ్యాక్గ్రౌండ్ పెట్టి ఎంజాయ్ చేద్దామని సార్.
అదే అంటున్నాను.
Suresh, recorded the thing we can start now.
Recording thing we can start, sir. 8:30 now.
I think we'll start because Valdev Murli has not joined. I'm waiting for. I'll call him once.
Yeah. We can start the recording session, sir.
I'll call.
Sir, Jagdish sir, మీరు స్టార్ట్ చేయండి.
ఇది రికార్డింగ్ సెషన్ అంటే ఎవరిది ఇది ఫస్ట్ టాక్?
యాక్చువల్ గా నవీన్ జైన్ ఫస్ట్ ఉంది సార్. నవీన్ జైన్ is doing a panel on NNF now, right now.
Okay. So we'll start with
So మన దగ్గర రికార్డింగ్ ఉంది. We can start that. He will be there live as well as he will answer questions.
Yeah, we can start.
Murli has also joined.
Murli also joined. No problem. We'll start. Yeah.
So నవీన్ జైన్ ఎవరు ఇంట్రడ్యూస్ చేస్తున్నారు?
వాసుదేవ్ మురళి గారని మా సీనియర్ ఉన్నారు ఆయన. అండ్ జగదీష్ చంద్ర సార్, మీరు ఇంట్రొడక్షన్ తో స్టార్ట్ చేయండి సార్.
Sir is joined. Naveen Jain sir is on. Yeah, good evening, sir. Sir, will you present, sir? Recorded one shall we? You are there.
Good evening. Dr. Suresh is having the videos and I will be there as the videos plays. So.
Good evening, Naveen. How are you?
Good, sir. Thank you so much.
You're welcome. So,
Yes, Suresh, we'll start then.
Yeah, we
Okay.
can start, sir.
Good
Suresh, you
evening,
can
all of
introduce
you.
or
We are in the middle of the newborn week. In fact, on behalf of Pediatric Academy of Telangana State, we are starting our DAAP program, which is supposed to be on Wednesday. Now we have shifted to the Thursday for the convenience of some of the members have requested to have it on Thursday. And we have taken a newborn topic, which is wrapped for the newborn week, which we are doing from August 15th to 22nd. Yesterday, our state NNF has done a webinar on the preterm. And today we are having a neonatology CME on commemoration of the newborn week. Invite Dr. Ravi Kumar, who is the Vice President of Central Zone, Central IAP, and our senior member who is very well known in the neonatology circles. And Sir has been given Lifetime Achievement Award at the UP conference, Dr. Kbg Syndrome Sir, and Dr. Baldev Murli, who is the professor of Gandhi Medical College, and he has retired. And he is practicing at Hyderabad, and he is the senior most faculty and the neonatologist from the Hyderabad. And we have our Dr. Suresh Surapaneni, who is an executive board member of Pediatric Academy of Telangana State. And he is the first DM neonatologist who has reached Hyderabad, started his neonatology practice almost now it is 20 years ago, I think, if I'm not wrong. And Sir is in the neonatology practice. And we have two esteemed faculty. One is Naveen Jain sir from Trivandrum. Another one is Pankaj Agarwal from the US. So both the speakers are very well known. I think we are going to have a very good session. With this introduction, I request the chairpersons to take over. Dr. Ravi Kumar sir. Dr. Ravi Kumar, kindly, I request the Central IAP, our Central Zone chairperson, to say a few words, and then I thank Dr. Piyush Gupta, Dr. Bakul Parekh, Dr. Basvaraj for giving this opportunity on a DAP platform. Thank you very much, Dr. Ravi Kumar, for your address.
Surender, topic Surender.
It's a newborn week. 15th to 22nd is the newborn week. So, on commemoration of newborn week, we are having a neonatology topic today.
First and foremost thing, good evening, everybody. I'm in a different meeting, but I'm not able to speak totally. But the newborn care for the last 2 decades, it has improved a lot because of either the NNF or IAP newborn celebration. Lot of knowledge has been shared. Now we are able to see each and every smallest town also neonatologist. I have done in one small town 30 years back, Exome transfusion. It was appreciated by medical colleges and every small town, nobody used to do. But today, each gully, each small, forget about village also, people are able to do lot of neonatal procedures, lot of neonatal care. 1 kg baby surviving is good because the knowledge has been spread so much to the society and doctors are able to handle that. So thanks to IAP and the NNF and the persons like this Suresh, DM neonatologist, Ravi Shankar, all these people, they have inspired the most of my postgraduates to do neonatal care. Forget about DM. Today, we have applied for another 5 DM posts. Already, we are having a 3 DM posts, DM seats in Nilofer. And today, to enhancement, another 5 DM neonatal seats we have applied today. So I hope some students are going to get benefit. So thanks to this excellent program, and I'm extremely sorry. Once again, I'm telling sorry. I'm not able to participate at my full hearted. Thank you very much, Surender. Jagdish Chandra, please pardon me.
Thank you, Ravi. Our Secretary Pavan Kumar is not able to join. I request our chairpersons Dr. Jagdish Chandra sir, and Dr. Vasudev Murli to introduce the speakers. Dr. Vasudev Murli will introduce the Naveen Jain sir, and Dr. Jagdish Chandra will introduce Pankaj Agarwal. Vasudev Murli sir. Unmute sir. Unmute. Sir, unmute.
Opening remarks, Surender.
Yes, sir.
Opening remarks, importance of these topics.
Yes, sir. You can give, sir. No problem, sir. Both the chairpersons take over and conduct the today's.
Thank you, Dr. Surender and Dr. Pats, for giving us this opportunity, myself and Dr. Vasudev Murli, to chair these very important sessions on newborn care. As you all aware that there are nearly about 15 million neonates are born preterm every year globally. The survival of the preterm babies has significantly improved because of the availability of NICU and other improvement in sanitation, reduction in malnutrition and other factors. But again, it comes with a small problem. Infants discharged from neonatal intensive units have a range of risk factors that may result in medical and developmental sequelae. So this topic which has been selected today, there are two topics which have been selected today, which are of utmost importance and address these problems totally. Dr. Naveen Jain is going to speak about the developmental therapies and other early detection of developmental problems and how to manage them. And then we have got Dr. Pankaj Agarwal, who is going to talk about newborn care in genomic area. May I request Dr. Vasudev Murli to introduce our first speaker, Dr. Naveen Jain.
Good evening, everybody. Am I audible?
Yes,
Yeah.
So it's my privilege to introduce Dr. Naveen Jain, who is a senior consultant of KIMS Health at Trivandrum. Recently, we are fortunate enough to meet him in person. The recently concluded a conference of breastfeeding. So nice to see you back, sir, again. He's DM from PGI Chandigarh and MD from Trivandrum. His introduction is very brief. He just said he's editor of Clohati, which is like Gita of neonatology, and editor of Illingworth textbook of child development. The two words will speak volumes about you, sir. So nice to have you again, and we are very eager to listen to you. Over to you. Thank you.
Dr. Suresh, you can start the moderating.
Yeah. Good evening, everyone. So we have chosen these two important topics. One on how to recognize a sick newborn and how to do developmentally supportive care in NICU. And from Naveen Jain, who is one of the senior most and dedicated neonatologists from Trivandrum. And we have second speaker also. So both are very important, as chairpersons and seniors have already stressed already. So without wasting much time, I request Naveen Jain to start the talk.
Sir is there? Suresh sir is there?
No. So we will start with the recording.
Okay. You are starting or?
No. The IAP has to start. So shall I start from my system?
Sweta?
Yes,
Are you
doctor.
there?
Yes, doctor.
Yeah.
I have the recording.
Yeah. You
Play.
can start.
Okay.
Shweta, any problem is there?
Are you able to see my screen, doctors?
No, it is coming as white patch only. We are not able to see.
It's a blank screen.
Yeah, now we can see.
Okay.
NIBP it is showing.
We're
It's
not
again
able to
blank
see.
only. It's only blank. It's blank.
It's only
Shweta, are you there?
Yes, doctor.
You are not able to see the screen.
You're not able to see?
Yeah.
No.
Just a moment, doctor.
Dr. Suresh, you don't have the recorded version.
Yeah, I have, sir.
Was a 12-year-old boy who fell down in the basketball court. 2 days later, he developed fever and was hospitalized, then discharged to home with reassurance and paracetamol. Later evening, the child was brought back with tachycardia and succumbed to septic shock. This became a national fury in America. The parents, in reaction, developed a program called Rory's to. So you can see in this video, the national guidelines of US and this Rory Foundation are appealing to parents and doctors to recognize early changes in physiological signs to be able to detect sepsis or a sick child so that life may be saved. They have released the same thing as a poster. Do you have high fever? Are you breathing fast? Is your skin pale or mottled? Is there disorientation or loss of sensorium? Elevated heart rate? All these, if any of the sign is present, should suggest early onset of infection. The Rory Foundation has influenced sepsis-related deaths, and there has been almost a 12% decrease in sepsis case fatality because of early detection after these guidelines were implemented across the states. Once again, This is the same principle we are going to use in recognition of a sick neonate, wherever this baby may be, in your outpatient or in the emergency. We are living in this COVID world, and most of us are forced to assess and treat children or infants or newborns with even more limited information than we used to have. I get a teleconsult. Doctor, my baby is 18 days old. He has fever, 100 degrees. What should I do? What I'll end up asking and looking on the video, is he dull or poor in feeding? Does his feet feel cold? Do his hands feel cold? If he's poor in feeding and his hands and feet are feeling cold when there is fever, then I tell them to rush to the hospital. But if he's active in feeding, warm to touch on hands and feet, then I suggest to them that they make you paracetamol and reassess the child and call us again after 6 hours. I'm going to introduce to you a very simple mnemonic called STOPS. S stands for sensorium, T for temperature, O for oxygenation, P for perfusion, and S for sugars. We use this mnemonic to be able to assess whether a unit is sick or is well enough to be reassessed. We would classify these 5 clinical signs merely as good or bad, and this assessment should be possible by the parents, by a nurse, or even by a junior doctor, not necessarily a pediatrician who is senior or neonatologist. Let us look at a scenario. You have gone to attend a cesarean section of a 35 weeks pregnancy. Baby is born and is having retractions and growth. Now, what should I do? Should I wait or should I refer this week? That is the question that we always have. If I give you the same situation that it stops, his sensorium is good, he is active, his peripheries are warm, there is of course retraction and cramp like I told you. Refill time is good, heart rate is normal, and blood sugar is good. I'm sure most of you will agree. I think you wait and this baby and then decide. Whereas if some of his STOPS parameters are not okay, let us say he is lethargic, with cold peripheries, and early signs of poor perfusion, like capillary being poor or heart rate being high, then the same baby with retractions and cramp is totally different. You would have easily noted that you have taken a decision even without asking for an X-ray, blood gas, blood count, CRP, or a blood pressure. The decision to start antibiotics, refer to a higher center, keep near the mother, all can be decided by a simple 5-question yes or no decision. This is what we call a SOP. Sensorium, temperature, oxygen, perfusion, and sugars. We'll go to some of them in detail. This may be used by you to educate your team, nurses, junior doctors, to be able to speak a common language so that the baby may be assessed well. When a newly joined doctor comes to our unit and calls me from the emergency room or labor room to ask, sir, there is a baby, I think he is not well. There is a saturation of 88 or there's a sugar of 32 and he stops, doesn't give you more information. Then I ask him one question by one, and this is what I would ask him and we would assist him. I ask him what is the sensory of the baby. Is he active or lethargic? A baby who has a good tone, responds to touch or being uncovered, cries well, and has good spontaneous movement is an active. Whereas even when we are picking up the baby, he is not showing any response. Body tone is poor. He lies so loose as if there is no life. And anybody can say that either this baby is sleeping in deep sleep, which is not impossible, or he is lethargic and the sensorium is poor. Now, how do I know whether this is lethargy or it is a sleep that the baby is demonstrating? So I reassess the baby after 1 more hour. If the next hour also baby is lethargic and this continues the 3rd hour and the 4th hour, I become worried and I think the problem is severe. Any baby who remains sleepy or lethargic for more than 6 hours is surely having a problem. Just like we have a sleep wake cycle of 24 hours and we get sleepy, tired at the same time of the day every day, irrespective of what we had through the day, babies have a sleep wake cycle of about 4 hours. So every 4 hours, baby would wake up, become active, look around, even if they are 26 and 27 weeks. Absence of this sleep wake cycling or waking up is a concern. My nurses would often call me saying that, sir, something is not okay. Every vital is normal, but the baby has not cried for the last 4 hours. I had told the resident, but he doesn't take me seriously. She would go to the other room and call me, can you please come and see this? Then we would evaluate all his vitals, make sure that the other sickness indicators are picked up early. He may be a case of sepsis and may want to start antibiotics. If the sensorium remains abnormal for more than 24 hours, baby doesn't wake up, doesn't cry, he surely has a primary CNS pathology. It may be HI, it may be intracranial hemorrhage or meningitis. This baby may require CSF for infection or imaging to find out what's going on in his brain. A baby who is encephalopathic or dull more than 24 hours is concerned. Way back in 2003, we wanted to audit our data of babies who are transported from other hospitals. And we found that death or disability was predicted better by encephalopathy for 24 hours more than the need for ventilation, shock, or the first pH, like in many of the sickness scores. Similar findings were found in a very large population-based NICHD study 3 decades back. They found that not crying, less active for 24 hours was the strongest predictor of cerebral palsy in the NICHD. The second component of STOPS is temperature. The normal temperature is actually warm hands and feet and not just 36.5 to 37.5. We know that babies would undergo cold hands and feet step far before they would get hypothermic in the cold temperature. We need to get them up at cold stress level. If your unit is making a first diagnosis of 36 degrees, we are missing early signs. And therefore, more than the thermometer, we need the dorsum of our hands to touch the abdomen of the baby and the peripheries to find out what is that with the dorsum of the hand, we're touching the abdomen, chest, and then the peripheries. I just replay the video for you. You first touch the peripheries. Is it warm or cold? And then touch the abdomen and chest. If the baby is cold on the hands and feet, the temperature difference is more than 2.5 to 3 degrees, and this is a sign of either low environmental temperature or sickness. So what would you do? You would check the room temperature. Is it too cold? Remove his wet clothes, clothe the baby well, and again reassess after 15 minutes. If the baby still feels cold to touch, you may do active rewarming by either KMC or a radiant warmer and reassess again. A baby who also has more heater output than what is normally required. You can see the cartoon on the left side. In the summer, if it was a conference that we are attending, not on the Zoom, if most people were sitting comfortably in an air-conditioned conference room, but one of our colleagues was shivering, wearing a monkey cap and 2 sweaters, we would think either he is developing an illness or we would think something is wrong with his bonkers. And the same would be with a baby who requires much more heat from the warmer than most other babies in the unit require. So most babies would remain warm with only 25% heat or less required from the warmer. If you see that this baby requires 50% heat, you can see this display is there on the warmer, which shows how much percentage of full heat potential is the warmer giving to your baby based on the baby's needs. based on the thermistor's detection. So if a baby requires 75% heater output, this baby is critically ill, and surely 100% heater output is very bad. At our own request, companies have now started indicating 50% and above heater output in a red color, suggesting to the user that if a baby is requiring 50% or more heat consistently, this baby is seriously ill. This is the monitoring chart of our unit, and it shows that the baby's peripheries which were warm are now becoming cool, and a baby who was requiring just 25% heater output earlier gradually requires more and more heat to remain warm, 50% and then 75%. This baby is getting sick. I may evaluate whether his perfusion is getting poor, he may be getting sepsis, an intracranial hemorrhage, something seriously. The third component of stops is O for oxygenation, and I would assess based on two parameters. One is the saturation and other is respiratory distress as measured by respiratory rate, retractions, grunt, and oxygen. Among these, we would place more importance to retraction and grunting than to the respiratory rate.
The baby is having difficulties. Knowing what to look for will help you know if your baby is in distress, such as dual breathing movements.
I know
with each breath, your baby's chest muscles pull in the skin around the bones.
They recognize well what is retraction and what is grunting. I just wanted to show this for the benefit of
They grunt to keep air in the lungs. Grunting may sound like snoring or singing. Apnea is a condition in which your baby
at your junior doctors, and the WHO manual of newborn care indicates only two indications for applying CPAP or invasive ventilation, and that is retraction and grunting. They are not talking about respiratory rate or saturations. The presence of retraction and grunting indicates need for pressure to treat the baby. Similarly, this is the CPAP circuit, which all of us know and very easy to apply. So the presence of retraction or grunting indicates need for CPAP or invasive ventilation. The baby should have a saturation of 90% or more, but if he's on oxygen, mind you, we do not want hyperoxia. The saturation should be kept less than 95%. This is the kind of oxycode we used to use in PGI way back in 2000. The helmet kind of oxycode is not good for unit use. This oxycode you can see has two holes, what we used to call the port holes on the side. If you give 5 liters of oxygen flowing into this oxycode, it would mix with the air around and would maximally give around 30% oxygen to the baby. If you close one side of the port hole, as you can see in the picture, then the baby lands up getting nearly 50 to 60% FiO2, much higher than what with both the holes open. And if I have to close both the holes, that means deliver mostly only oxygen with no air mixed. This baby is critically ill and needs to get referred immediately. The fourth component of stops is perfusion. I would label as either normal in green or abnormal in red, based on capillary refill time, heart rate, and blood pressure. Other findings that may help me to understand is the urine output, baby's activity, which we assessed earlier, and presence of cold values. Capillary refill time in newborns is done on sternum or forehead than on the palm like in older children.
In order to perform the capillary refill,
you can see that pressure is being applied to the sternum of the baby, and you can see the refill time is slow. I would count 1,000. Yes, 1 in 1,000, 2 in 1,000, 3 in 1,000. It is taken longer. And some people make it easier that after you start testing, I'll show you again. After you start testing, you simply chant the word capillary refill time. If the refill has not happened till that time, then the capillary refill time is slow and the baby is having poor perfusion and needs assistance and help. Heart rate is also very useful in newborns, and a serious study of the heart rates can indicate early diseases. You can see this baby had a heart rate of 110 at 8 a.m. and a good refill time. Over the next 4 hours, serially, the heart rate kept increasing. And also the refill time became prolonged. This baby is getting seriously ill. Blood pressure, if available, would add on to more information in assessment of perfusion of the baby. Once again, the one-time assessment is not the endpoint in a sick baby. Every 30 minutes, you would reassess. Most of us are very conscious about low blood sugar values of less than 40, but a value of more than 125, if the baby is getting the standard glucose infusion rate, is also high and indicates stress in the baby. Now, can this stops be used only for sepsis, or it can be used to assess any sick baby? Let us look at this situation. A baby did not cry at birth. As a pediatrician, I have to take decision whether I need to refer this child or to a cooling center, or whether I need to wait and watch whether this child will get better after the early resuscitation is over. You can see if this child remains lethargic, has cold peripheries despite rewarming under a warmer, even if his saturation is reasonable and his heart rate is bad, his perfusion is poor, this child probably has multi-organ dysfunction and needs to get referred for cooling or potential cooling. I did not use an MRI or a cord blood test till now. The same baby is lethargic, but his peripheries are warm, his perfusion is good and sugars are good. May give me some more time to reassess after 1 hour whether his poor sensorium is improving or not. This must be recorded periodically to make better decisions. Let us look at another scenario. The baby is born premature at 32 weeks, and I want to decide whether I can start CPAP, give it surfactant and continue CPAP in my own unit, or do I need to refer this baby to a center where invasive ventilation may be required. Let's see if this baby is having a good sensorium, little cool peripheries, retraction and grunting is there, he has got RDS for sure, but he can maintain saturation of 30% oxygen with good perfusion and good sugars. I would probably give CPAP and maybe surfactant and wait my 1 minute. Whereas the same setting, the baby has either poor perfusion showing his high heart rate here, or you can see requires 60% oxygen to maintain the same saturation. Remember, when both one side of the oxygen has to be closed, it is 60%. If both sides are open, it is 30%. If you have a blender, of course, you can directly measure the FiO2 being delivered. Can I use stop in level 3 NICU or tertiary NICU, or it is only a poor man's tool for units where resources are not available? I must promise to you that it is on stops that our unit works in the last 20 years. We use this tool very religiously. Every baby's note who is not well includes the first assessment, like the triangle of assessment in pediatrics, as stops. The last week we had a 750 grams baby who on 12th day of life had significant ET bleeding. The question was whether he is developing a ventilator associated pneumonia and requires an antibiotic change, or is it just a local trauma on the trachea and bleed and we can wait and watch it. If this baby was lethargic, cold to touch, needs some oxygen, has a poor refill time and bad heart rate, has high sugar levels, this baby has stress either in the form of sepsis or intracranial hemorrhage, he is not well. The same baby with ET bleed has rest of the stops normal, is otherwise active, warm on touching the peripheries, good heart rate and perfusion, sugars are normal. I think we can wait on this baby. We need not jump on doing culture, CRP, antibiotics. The question most people would be asking, is this just a local idea or is this stops tool validated scientifically? My student Jamila has done the same research work, and Vishal and Jamila together have published this paper recently, last month. And this paper discussed her work which she did over 3 years. She enrolled 235 babies with suspected early onset sepsis. You can see that the positive likelihood ratio, the chances of predicting a bad sepsis when it came to procalcitonin more than 2 was only 1.3 times. That means it only increased the chance of having sepsis by a very small amount. Whereas if there was a persistent temperature abnormality at 12 hours, poor perfusion at 12 hours, the prediction was 9 to 10 times and was a far better predictor than a positive procalcitonin. We put the same data together in trying to look at procalcitonin values done at 12 hours or a stop sign at 6 hours, any one sign of normal. In such case, if we did not treat babies if they had all stops normal, then 31% babies only would get unnecessary antibiotics for just one sign. But if we treated babies for a positive procalcitonin, 44% babies would unnecessarily get antibiotics. And you can see in the next column, the number of missed cases of sepsis would be the same if we use these alone. Of course, a combination can improve the outcomes still further. In the same study, we went on to find that if there were 2 signs abnormal than 1, then the positive likelihood ratio increased more. That means the infant or the neonate had poor perfusion and poor sugars. Or like in this table, the baby has poor temperature, cold peripheries, and poor oxygenation, requires 60% oxygen, has retractions in the gland. Then the chances of having a seriously ill baby or new onset infection is far more than if it was only one sign positive. Similarly, if the same sign persists over the next few hours, the temperature abnormality does not return, like I showed you in the previous slides, that at 12 hours, if temperature abnormality was still persisting despite rewarming in the unit, then there was a 9th time increase of infection than in the previous row. You can see at 6 hours, only 2 times increase of infection because it may be just due to cold stress. Can I use stops in a non-intensive care setting? President calls me from the emergency room saying, sir, there is a referred baby, 8-day-old, whose outside bilirubin levels are 21. Shall I start doing an exchange or can I start doing intensive phototherapy and reassess after 4 hours? I ask him what is the stops. He says, sir, the baby is lethargic and cold to touch despite rewarming. These are the same early signs that IAP has recommended as signs of early encephalopathy and need for early exchange transmission. A baby who is active, warm to touch, feeding well, may wait with only intense phototherapy. So am I trying to say that our stops can do everything? Is it really a supercomputer? Please remember, the supercomputer works only on 2 variables, yes or no. And the combination of various variables that it can do at a very high speed in a predictable algorithm is what makes it a supercomputer. Whether you have a basic simple phone, a very, very ordinary computer, or a supercomputer, the language is just the same. Sensorium, good, bad. Temperature, good, bad. Oxygen, good, bad. Perfusion 0, 1, sugar 0, 1, and then computes on the algorithm and gives an information. Friends, we need to only do simple things well to be able to do good and very, very important and effective outcomes to our children.
So that Naveen's first talk is over. That Naveen.
Yes, Suresh.
Yeah. So you want to say anything?
Just that subconsciously, as we mature in our career, that means whether it is Dr.
You have muted yourself.
We are doing these jobs every day without realizing it. But what we need to do is we need to make sure our residents or our nurses are also using the same multi-component primary survey, as we call it. Otherwise, I can remember stories where residents have intubated a 28-weeker and very happy because saturation is okay. but do not realize that the baby's sensorium is bad. Or coarctation of aorta is managed with prostin, but you forgot to look at sugar. And therefore, if your team, primary team, you educate them, doctors and nurses, young doctors and nurses, to do what is called primary survey of all the 5 components every time that a baby is not well, then you will not miss any major problems in the unit.
So we'll go on to the second presentation as we are running short of time. Can all of you see the screen?
Yes, it is now clear.
Yeah. Yeah. There's a noise from some other source.
I'm sure we all have this experiment. We have a science teacher to put a sapling in near the window, and we found consistent. Sometimes finding beautiful spirals. You can see even the lowest form of creation in ontogeny. The way to sense.
Dr. Surendra, you have to mute yourself. Lot of noise.
Towards the right stimulus. So for all those friends who were looking for scientific evidence that giving the right stimulus at the right time can change the path of growth for the better, what we have called previously as neuroplasticity, there is evidence even in simple facts. In daily practice, we as pediatricians tell our parents to spend quality time with the child. Specialists, developmental pediatricians, neurologists who believe about autistic behaviors happening if the child does not get special stimulus from the parent at the right time and at the right age. It is called as joint attention, which is a very important part of learning, where there is a synchrony between the mother and the baby. And almost like in sci-fi movies, everything that the mother has learned, she is transferring to the baby. You can see the image by joint learning. And even in the image on this side, you can see how learning happens. The mother looks at an object, she speaks about it, and even the child is learning, which means it is possible to modify a child, his brain, at the stage of young infancy and childhood, learn something, which means we must be aware that the formation, growth, synapses of neurons in a newborn, in a preterm, in a fetus is happening at much faster rate than child. This is a very simple experimental model. Mice are placed in cages where they have food to eat, a slide to play, something to smell, some activities to do. This has been one of the most important experiments to prove learning through experiences. Mice who are born preterm were placed in 3 different types of cages. One is standard condition, very similar to our NICUs, where we have mice but not much of food stimulus. The bad condition where mice mice is placed alone with no family members visiting the mice, and an ideal condition where there are both family members as well as there are activities to do, things to play, and the right stimulus at the right time. And when these mice were later sacrificed and they were studied, the mice who were in an enriched condition had rich synapse formation. The neurons were connecting with each other. Important transfer of information was possible, whereas the mice who were in condition where there were lack of stimuli, there were no synapse formation. So it is the presence of a stimuli which causes or induces a synapse formation, like you saw in the plant, like you saw in the child who learns his language only if it is taught. So having a bad condition where your preterm babies spend time in the NICU for weeks together without the right stimuli from the parents is going to create babies with neurons which are like cell phones, which don't connect, which are no network. So if you want a baby to be having the right development in the form of synapses, then it is just not enough to give stimuli. It should be the right stimulus at the right time. And this can be given only by the baby's parents. They should touch, talk. The body smell of the mother should be offered to the baby. They should be having the right conversation with the baby. And this is so critical. Each part of these mice was stimulated appropriately. You can see the presence of right things to see than always the walls of the NICU. The baby should see the mother's faces. He should see some colors and lights for visual stimulation, for the visual cortex to grow. They should have some movements in the NICU, both passive and active, rather than just lying fixed in a position in the bed to have motor development. The baby should be given some reasons to act and respond. There should be somebody stimulating the baby to respond back. And here you can see once the baby starts doing normal things like he would have done, and he would develop somatosensory qualities. Coming to things we could be doing incorrectly, we all are very conscious who are looking after babies and putting cannulas or applying a nasal prong. And we keep checking every day whether there are injuries. We have scales for measuring nasal injury due to prongs. We have EIP score for measuring extravasation of cannulas. We are very conscious about these because these are injuries we can see. The injuries we are creating to a growing brain, which are due to a very noisy environment, a painful NICU stay, too much of bright lights, foul smelling, hand rubs, all these we can't see. This is what was the past, but today by doing special imaging techniques like the diffusion imaging, fractional anisotropy, tractography, we are able to track each single of these that I showed you in the previous image and find out that the baby is having injuries due to bad stimuli or developing normally because of good stimuli. So there are serious injuries we know now. We can see them to the development rate by studying the microstructure. So we know that, or we have proof that preterm babies have brain changes that are happening very fast, and when the babies are in NICU, and these are associated with the experiences they have in the NICU. There could be deviations in development from normal if the baby experience is not similar to what it should have been in utero. It's also important to know about the critical timing of these stimuli. In this experiment, preterm mice were given a startling sound, sharp sound, and they did like this. After some time, another sound was given, and again they started. When the third sound was given, the preterm mice didn't respond. This showed that they had learned about this experience. This is called habituation. and it is a proof of memory and learning. This was happening well on the first day and second day, but from third to seventh day, the mice did not show good learning to the same stimulus, beyond which this learning experience returned again. This experiment demonstrated that each stimulus has a right timing to be presented, and by knowing what the fetal senses are and how they develop in time, we could plan which stimulus should be exposed to the preterm neonate in the NICU at the right time. The timing of interventions are very, very critical. It is not enough to think that let the baby become better, survive and go home, and then we can start stimulating the baby. It may be just too late. Many of the learning opportunities, the right growth of synapses and directions of the fibers may have lost an opportunity and never to be repaired again. One experiment was that with mother's voice, and this experiment became popular or necessary because the previous experiences with comforting music in the NICU, like the Beethovens and the Mozarts, did not produce all the desired changes that they wanted to measure. Then people thought maybe the baby should be hearing what he was supposed to hear. So the mother's heartbeat, the uterine souffle, mother's breathing sounds were recorded and continuously played into the incubator by a device called Baby. I saw this device in Italy when we went for a DSC workshop, and it was something like 6 activities. In India, probably we have to improvise and have a more real and cost-effective solution like KMC, where we would continuously hear the mother's sound without the need of a device of this kind. Also, that babies who heard the mothers speaking to them in adult language, that means babies, mothers and fathers talk to the baby, they had better adult language development at entry of school age. So what we have learned is clearly that the baby should be presented in NICU, even if it's a 27, 28, 30 week, 32 week birth, for the days that he spends in the NICU with mother's voice, and through AMC, the baby should hear the mother's heartbeat and the respiratory rate as long as possible, and noise should be avoided. There is clear physiological proof also that when noise increases, the baby's sleep is disturbed, baby cries longer, and the intracranial. So what we have learned so far, the brain damages are happening in the NICU. We can now see it by sophisticated imaging techniques. Noise is surely damaging. Please try to reduce the noise in your unit. The alarm should be avoided. Maternal voice or adult language improves the language development, and interventions may start as early as 30 weeks because in fetal ontogeny, it is by this stage that the babies respond well to sound. Similar experiments were done with smell. We have all noticed that the babies sneeze and become irritated when we take a hand rub near the baby. So it was shown that the babies love the smell of colostrum, which is expected, of water, but vanilla or even the method used for removing, that includes hand rubs and alcohol-based rubs, cause irritation to the babies and is not a good thing to do. When the babies were presented with the smell of milk by either applying a drop to the mouth before feeding by tube feed, this is both colostrum mouth paint and even continuing later, that every time a tube feed is to be offered, one drop is put into the mouth, the babies had good growth of their gut, they gained weight well. We all know that if we were in real physical conferences, when we start getting the smell of food in the next room, our hormonal production starts
We're not able to hear.
Not audible.
Doctor, kindly unmute yourself.
It is recorded.
Okay.
Not audible. Audio is not working, please.
Experiments from India, they have shown improved sleep time, better heart rates, and lesser apneas, better weight gain in babies who had a surgical unit. The right position is important. The babies need to be brought into a reclined position, and swaddling them like they would be in in utero improves the tone and reduces motor delay. The babies must be positioned alternately and not in the same position all the time. So we have learned today already that NICU experiences do improve the brain development. Babies need to be placed in the right position in the NICU. They have to have a massage, oral stimulation. They have to be presented with smell and taste of milk before they given a orogastric feed, so that they would have better hormones and growth. This is one schedule of the unit showing how the lighting needs to be reduced during the evening and reduced to something as a minimum. And also, if the babies are normally requiring bright light for care during the rest time, it should be reduced to below 200 hours. And this is very critical to help them sleep. In our unit, we have integrated the development supportive care into intensive care. Otherwise, it becomes second importance and gets forgotten. On day one itself, the welcoming mode includes not just intubating the baby, doing blood sugars. It introduces to the parents the need for this program called early parent participation, and that they have a role from first day. The mothers are given a breast pump at birth, and as soon as the baby is stabilized in NICU, the staff goes to the mother and educates her to start expressing milk by the time the mother is out of the labor table. By the third day, there is a reminder that parents need to touch and talk to the baby. The doctor and nurse has to tick that this has been done, and the position assessment tool ensures that babies are placed in flexed midline and also changed positions. By 1 to 2 weeks, there are reminders that we should have started baby to suck at an empty breast if it is stable. KMC also should have started. Oral stimulation also has been started. This process continues till the baby is in the NICU. One such thing which has found popularity and is very useful is kangaroo care, where the baby can hear the mother, feel her touch, smell her. It improves mother's breast milk and should be practiced for longer hours. It requires a lot of commitment from the unit to ensure that long hours KMC should happen. It should be supportive to the mother in the form of privacy, comfort in sitting, and also somebody encouraging and educating the importance of the same. The one step ahead is single room NICUs, where the baby would be getting intensive care in a larger room with the family also there, and the family allowed to live and continue in the way they would have done at home, and baby getting the same environment as would be at home with siblings, parents, grandparents to be around. This is called as couplet care and is catching up in most of the world. Before I conclude, I would remind that this is not just something soft which nurses have to do, or which is of secondary importance following hypoglycemia, asphyxia, or inotropia. If you want the baby's brain to grow normally, then you have to give them the right stimulus at the right time, starting from day one in the NICU, and the stimuli being presented at appropriate ages throughout the NICU period. Please remember, if you want the baby's brain to grow in the right direction, then do it before the plant dies. Light is required for the plant, stimulus of the parents is required for the baby's growth. Thank you for your attention. Please remember, together, nurses, parents, and doctors, we can all make a difference and improve the outcomes of the babies. Thank you so much.
Thank you, sir. It was really enlightening. Very simple points you told, and it's really very useful for the. I don't know how many youngsters are there in the group, but I think we have to propagate this, and we are really. You made our evening, sir. It is really enlightening lecture we had today. Thank you, Suresh.
Dr. Naveen, Dr. Naveen,
Sir.
can you hear me? Yeah.
Yes, sir.
See, you have spoken about dynamic lighting in the newborn unit. And also, I think noise level detectors should also be installed in all neonatal units so that the decibel rate does not go more than about 60 or 50. It is maintained around that. So that will help the baby. And audio, visual, tactile stimulation, what you have already stressed, I think it's going to make a lot of difference. I think all the neonatal units should be given these protocols about the lighting, about the audio, visual, auditory levels and other things. So once we take care of these things, I think it's going to make a lot of difference in the babies improving their general status and all. So I think you should prepare a protocol wherein it can be circulated to all the NICUs. And the method of giving the massage also, the stress points and other things, I think it should be made very clearly. It should be illustrated very clearly so that it's circulated in all the NICUs, and maybe the level 3 units have all these facilities, but we should see that the other units also try to maintain these standards.
Thank you, sir. Thank you, Jagdish Chandra sir and Vasudev Murali. And great thanks to Naveen Jain for doing two topics. So one on recognizing sick newborn and about newborn follow-up and how to maintain. It reminds us that they are our babies, and the human part, the human touch inside the neonatal care. Neonatal care is not just machines. Neonatal care is people. People and motherly touch. We are extending mother's womb. NICU is the extension of mother's womb, that we have to remember. So thank you very much, Naveen. So we have Dr. Pankaj Agarwal from Boston online. So I request the chairpersons to introduce you. Welcome, Pankaj.
Thank you, Suresh.
Good evening, Dr. Pankaj. It's my pleasure to introduce Dr. Pankaj Agarwal, who's attending neonatologist director of the Neonatal Genomics Program, Merton Burnfield Chair in Newborn Medicine. He's the principal investigator in the and medical director of the Manton Center of Gene Discovery. He's director of Neonatal Genomics Program, Boston Children's Hospital. Associate Professor of Pediatrics, Harvard Medical School, Boston. Associate member of the Broad Institute of MIT and Harvard. He has published more than 120 papers in several high impact journals, including New England Journal of Medicine, JCI, and others. American Journal of Human Genetics, PLO Genetics, Genetics and Medicine, and others. He is an investigator for the Undiagnosed Disease Network at Harvard Medical School, Center for Mendelian Genomics. Received several awards for his clinical and research work, and has presented his research in several national and international forums and conferences. So he's going to talk about the care of the newborn in genomic era. So over to Dr. Pankaj Agarwal.
Hi, good evening, everyone, and thank you so much for your kind introduction, Dr. Jagdish and Dr. Suresh. And so I'm just going to go straight to. So a lot of people ask me, like, you are a neonatologist, why do you do genomics? And I will say that I was a fellow at Boston Children's Hospital in 2000, and I took care of this individual who is unfortunately no more. He died, in fact, sadly last week. But he was born as a baby who was treated as a child with perinatal asphyxia because his APGARs were 0, 1, 1, and was extensively worked up because he would not move a muscle. and turned out that this child had a genetic condition called myotubular myopathy. So it's a very rare condition, and basically these patients have
Sorry
difficulty
to
moving.
interrupt you, sir.
Yes.
We are not able to see the screen.
Oh, so let me just. Why is it paused?
Maybe you can share the screen again, Pankaj. You can stop sharing and start again.
Okay.
Yeah. Yeah,
Can you
right.
see it now?
Yeah,
Yes.
right.
Now we can see.
Okay, let me know if you don't hear me or don't see my screen. So anyway, so this I don't know if you heard me, but this he was 20 years old. He just died, but he was taking care of this loving family who said we are not going to redirect care and we are going to do everything for him. And he, as you can see, he has a tracheostomy, he has a gastrostomy hiding behind his shirt, and then he was on a wheelchair. And it was just this family made it their mission to help to research in this field and advance care for patients with myotubular myopathy and other types of muscle disorders. So this is how I got inspired into learning more about genomics, and this is where I start. Let me see if I can. So, as I said, I'm going to talk about how genomics can make a difference in the care of newborns. So we can divide that into how it can make a difference in the NICU, how it can make a difference for healthy newborns, how it is making a difference in understanding genetic conditions when a baby dies unexpectedly, and then a lot of research that we are doing now, including gene discovery, reanalyzing data from exomes or genomes, and we have built this neonatal genomics program at our institute, and we're going to talk about it a little bit. So as I'm sure we occasionally see these type of patients where we just cannot figure out why this child is so floppy. So at least in here in the US, they go through a lot of testing, and some of these testings are shown here. And think of having one test that can give you a diagnosis, and that can be an exome or a genome sequencing. So this is where we are trying to push for this type of testing for unexplained hypotonia, for example. So we decided to study this in our NICU, where we wanted to see how rapid sequencing in the NICU can make a difference to the care of a baby. So we did a case control study where we enrolled NICU babies within a week of admission, and this study was performed at Boston Children's and Mass General Hospital. And we analyzed their exome within 5 days of enrollment, and we wanted to study the diagnostic yield, the time to diagnosis, the impact on care, and then number of diagnostic tests and costs. And then we selected certain phenotypes that we thought would be most likely to yield a diagnosis on exome sequencing. I just want to make sure that everyone knows exome sequencing, and it's sequencing the genes within the of the genome. So it's about 1 to 2% of the genome, while genome is sequencing every base pair of the genome. So we chose hypertonia, seizures, multiple anomalies, complex disorders of metabolism, and interstitial lung disease, immunodeficiency, and disorders of sex development as the phenotypes that we were interested in figuring out. So we started this study in March of 2017, completed in October of 2018. We approached 57 families. We enrolled 52 of them and sequenced 50 trios, or the proband or the patient and both parents. So in 29 of those 50, we could find a definitive diagnosis or a likely diagnosis. And in fact, very early in the study, we were almost running close to 90%, but as we opened up more cases, it became less likely to diagnose, but still we got a diagnosis of 58%. And we also got the data from 21 cases that were undiagnosed for reanalysis. So how did it make a difference? So many neonatologists ask me, like, if you give a name to a condition, how does it help? And I want to give you some examples of how it can help. One of those patients had a mutation in a gene called SCN2A, and interestingly, patients who have mutation in SCN2A are more responsive to phenytoin for seizure control. There was another patient who had a MTM1 mutation, and this patient was eligible for a gene therapy clinical trial. And there was another patient who was we could apply for emergency drug use for a compassionate use therapy. But in addition, majority of cases we could refer them to additional specialists, or it helped the families to make decisions about their the next child. And then it can also expedite some of the long-term management decisions, like tracheostomy or gastrostomy, where like the previous family I described, they decided to go for full care. And then some families make a opposite decision where they say, we don't want our baby to be subjected to so much, and so we want to go for a redirection of care, which means let the baby die peacefully in parents' arms. And so all these things can be expedited or helped when we make a diagnosis. The other thing to remember is that a lot of these families go through a guilt when their child is diagnosed with a genetic condition, when their child is diagnosed with, or when a child does not have a diagnosis, and they try to blame themselves for that. And it turns out that if we do find the diagnosis, that helps them to cope with that problem. So recently, I was funded from the NIH to study this approach in community NICUs, which are NICUs which are not in large academic centers like ours. And we got $6 million funding last month to use this approach, where we can build this center, which will be called Virtual Genome Center, or VIGOR. And we will enroll 250 newborns with likely genetic conditions from 4 community NICUs, and we will include those 7 criteria that I had already described, and we may come up with some new criteria as well. And then our aim 2 would be to facilitate sequencing, create reports, and reanalyze data. And then the aim 3 would be to examine how appropriate or feasible or possible it is to do this type of study, how it affects the equity and satisfaction among parents, their mental health, and the outcome of the newborns. So this is a recent study that we are starting now. So this was about the NICU, but what about the healthy newborns, like those who do not have any issues? So this was also studied by us recently in a study called a BabySeq study. So in 2013, the National Institute of Health funded 4 sites for a period of 5 years to study the role of genomic sequencing as a tool for newborn screening. As you know, in the US, there is an extensive program for newborn screening where more than 50 different genetic or non-genetic conditions are screened for using a proteomic approach. So how does genomic can facilitate that? That was the goal of this study. So the 4 sites that were funded by the NIH were Boston Children's Hospital, along with Brigham and Women's and Baylor School of Medicine, University of North Carolina, Rady Children's and Mercy Children's, and the University of California in San Francisco. And there was a program that was created for these 4 sites to work together, which was called the Ensight Program. So only 2 of the 4 studies really focus on healthy neonates. So our study and then the UNC or University of North Carolina study. The other 2 studies were mostly focused on NICU or PICU for Rady, and UCSF. They wanted to focus on metabolic disorder or immunodeficiency on the dried blood spots of babies. So this was our study. We did a randomized control trial where we enrolled 325 babies, majority from the Well Baby Nursery, and they were randomized to either standard of care or standard of care plus genome sequencing. And same thing for ICU infants, where we did randomize them to standard of care or genome sequencing. And in addition, if they developed a symptom, like someone develops seizures while is already enrolled, we could also look for seizure-specific genes. And then this study was extensively had a lot of ethical, legal, and social implications of this type of approach. So this was something that was focused on a lot in this study as well. So what we found was that out of 159 babies who were sequenced, 18 of them had something which was very interesting. For example, one of the patients had a syndrome called Kbg syndrome, and this was not diagnosed when the child was born, but did have some subtle dysmorphism. And then this child was confirmed to have a mutation in ANKRD11 gene. And then there were three patients where we could partially explain the phenotype. And then there were 14 where there was no obvious disease in the child, but there was family history of disease for some of them, like two of them had variants in Titan gene that is known to cause cardiomyopathy in later age. And then there were some which were, there was no family history of disease, and that also included Titan, two patients, for example, where there was no disease history in the family, but they carried potential variants that can cause disease in later life, especially for the parents. So this was an example which was very unique, that we found that one of the patients who, or one of the healthy babies, we found that the child had biotinidase mutations. So this, just for your knowledge, biotinidase has two types of presentation. One is a severe one and one is a mild one. And in fact, it is part of the newborn screening, where if a child has less than 30% of activity, it's flagged and they are started on biotin treatment. This child, in fact, had two newborn screens. One showed that the child had 21% activity, and this repeat one showed more than 30%, so that was not flagged. But because this patient or this infant was enrolled in a study, we found that the child had two variants, which means it's a recessive disorder, one pathogenic and one likely pathogenic. And then we did enzymatic testing and showed that the child did indeed have partial biotinidase deficiency. And the easy treatment is to give some biotin to these kids. And there was some interesting family history. For example, the older brother had some history of extreme eczema, and then there was some alopecia in maternal side. But anyway, the important thing to remember is that this was a completely healthy child, and he had a condition that was possible to be prevented in the future by treating with biotin. So a simple treatment. We also found that a lot of babies, about 9 out of 10 of them, have carriers for variants in recessive genes. So these are some examples, like about 46 of the babies had at least one variant, which means they are carriers for these genes, which means that if they marry someone who is also a carrier for that gene, that there is a 25% risk that that child who is born from them would have the disease. In fact, one of the children had was a carrier for 7 different variants in 7 genes. So this just shows that it's this carrier status is extremely prevalent, and those who take care of families who are born in consanguineous families, they know the value of how important carrier screening is, because a lot of the disorders are recessive. We also looked at how this all this work we were doing, how it affects the attitudes of the utility by physicians, the families, what were their attitude towards the sequencing, how satisfied they were, and how much they find as perceived utility, how useful this is. And in fact, we did a survey on 95 physicians, and they felt that newborn screening is more useful than newborn genomic sequencing at this time to identify patient's condition, manage care, and is similar to predict future disease risk in terms of genomic sequencing versus newborn screening. But in 10 years, this may change, and this approach may essentially increase and match with the newborn screening. So there is a lot of potential for this approach in the future. At this time, most of the physicians don't feel comfortable dealing with this type of information, so only 1 out of 4 feel comfortable with dealing this type of information from genomic sequencing, compared to 92% for newborn screening. And then while they were, all the physicians agreed that every baby should receive newborn screening, only 12% or 1 out of 10 physicians agreed to do newborn genomic sequencing as a test for screening them. So I think overall at this time we are not pushing for sequencing healthy newborns. But just to tell you a little bit about this study overall, this is the first randomized study of healthy and ICU newborns. High rates of pathogenic or likely pathogenic for disease, disease risk, and carrier status. And there were anecdotal evidence of benefit. I told you about an example where a child with biotinidase deficiency was diagnosed. It can also impact family planning. So one of those cases, there was a direct impact on the family. And then there was one case where we found a BRCA2 variant, and that helped the family to explain why there was a high rate of breast or ovarian cancer in their family. So physicians are not yet convinced of the role of newborn genomic sequencing in screening newborns, but that may change in the future, and we are doing more studies to understand the ethical, legal, and social implications of these studies. So anyway, this study raised a lot of questions, and it was in media when we published the paper in 2019. And as you can see, all this said same conclusions as I pointed out, that it is raising more questions, but something that is we have to stay tuned to see what the future holds. So this is about the newborn screening. Moving on to molecular autopsy. So I'm sure as neonatologists we come across certain babies who die in our NICU of unexplained cause, and we are unable to determine the cause. And this was I want to talk about a case we had, which was a full-term baby who was a normal delivery. First day was found to have some pallor, hypotonia, was feeding poorly, so was transferred to the NICU at the delivery hospital. So as part of the workup for any child who has pallor and hypotonia unexplained, they did a septic screen, they did head ultrasound, they did a chest x-ray, they did echocardiogram, looked at the eyes. Everything was normal. Child had an MRI, and that showed some mild abnormality, nothing that fits into anything. But there was a small lactate peak in magnetic resonance spectroscopy, which was something that was seen, but child overall did okay. They did a pretty extensive workup, including metabolic testing for plasma, urine, and CSF. Everything was non-diagnostic. They did a microarray, which was negative. So the child was sent home on day 18 on caffeine for periodic breathing and oxygen monitor. So it sounds like a case which may be something going on, but child overall did okay, so they sent home on caffeine. So anyway, this child, after 3 days of going home, developed several episodes of apnea and then seizures. Came to the children's NICU now, and we noticed that the brain MRI was markedly worse. And again, we repeated the metabolic screening, and it was negative. So at that time, we were enrolling patients for this rapid sequencing study. So the family was kind enough to give us the samples. We also did a skin biopsy to collect fibroblasts, to grow fibroblasts from the skin biopsy, so that we can do additional tests if needed. Anyway, the child died on day of life 27 and had an autopsy. And there was some some findings that did not point to any particular diagnosis. There was some CNS atrophy, there was some steatosis, and some left ventricular hypertrophy, but didn't fit into any diagnosis. This is a young couple who wants to have more kids, and they were very keen on knowing what their child had. And just to show that brain MRI, the first one on day 3 showed some subtle changes. There was some thin corpus callosum. There was some diffusion weighted images showing some abnormalities here. And this was done on day of life 23, which showed pretty, on diffusion weighted imaging, pretty the signal was hyper intense, which suggested a pretty severe damage to the brain pretty extensively. Anyway, so because the patient was enrolled in our study, we did rapid sequencing and found that the child in fact had 2 variants in a gene called HIBCH, and this is a gene that codes for an mitochondrial enzyme that is involved in valine catabolism, and its deficiency causes Leigh syndrome. Unfortunately, this child's extensive metabolic workup was always negative, and that was unusual. So we were not sure if this is the right gene or not, and we were thoroughly confused. And also this mutations, the disease is not as severe as this child had. So there was no consensus among the metabolic team or genetics team or us what's the diagnosis, despite we have done an exome. So here what This is just to show what are the two mutations. This is the frame shift mutation, which was pathogenic, and this was a missense change. Anyway, we were lucky because we had fibroblasts from this child, we could grow the cells and then evaluate them for HIBCH activity, which was markedly reduced. And that confirmed the diagnosis, and we published this last year. But then this family, using this information, went for pre-implantation genetic diagnosis, and they have now two normal boys, a 3-year-old and a 6-month-old, who are doing great. Anyway, they were very happy with us and decided to raise money for my research team. They raised $72,000 in 2018, and in fact, they did another fundraiser last week, and they raised $200,000 to continue this work. So the family was extremely thankful, and a lovely family who really thought that this is a mission for them to help more families who have similar problems. So, and then I want to go to the type of research we are doing, where we are really getting into gene discovery efforts. So in 2009, we established a center for orphan disease research, which was funded by a family by the last name Manton. So this is the name of the research center, which is Manton Center for Orphan Disease Research, that was established at Boston Children's, and we started enrolling patients with rare disease. And one of the first cases that we identified the cause of disease was published in Epilepsia, and this is the child, this is the mom, and we found that this child in fact had a unique SCN2A mutation, and this was the first time that SCN2A mutations were linked to Ohtara syndrome, which some of you may know have a burst suppression patterns of EEG and pretty severe seizure disorder. So this is a little bit about the Manton Center, which was established in 2008. And this is the part that I focus on, the gene discovery. We have a lot of success with publications, and we have an accessible biorepository, many novel genes we have identified. We have returned our results to the families, a lot of academic and industry funding, and engagement with the rare disease community. These are some of the projects that we have done thanks to the center's support. And we have also collaborated with many industries, including Alexion, Amgen, and Pfizer. So anyway, so the protocol is pretty straightforward. Any patient with an undiagnosed condition can be enrolled, and then we try to get their blood samples and also create cell lines whenever possible. And then we perform cellular studies on animal models. We have already enrolled over 2,400 plus families. Majority are N of 1 cases. We are sending exomes or genome for most of them. And we are using many resources for generating this type of data. And we have developed our own pipeline there. We analyze this type of data and use other sources as well. So we are doing gene discovery. We are doing these genetic modifiers. We're building cohorts of conditions for genetic analysis and support the development of personalized therapies. So these are some of the cohort studies that we are performing in collaboration with different experts. Some are ENT experts, some are surgeons, some are mitochondrial physicians. So they are enrolling patients with us, and we are trying to help them find the genetic basis of those conditions. Just want to show you an example of how we go for gene discovery. This was a patient who was a full-term normal vaginal delivery, had some tachypnea at birth, and was discharged soon after. At 2 months was noted to have some poor feeding, failure to thrive, and labored breathing, and was noted to have low SATs when he was evaluated, and was treated with oxygen and nighttime BiPAP. Child had extensive workup, including interstitial lung disease genes such as ABCA3, SFTP, B, and C. And then child was weaned off oxygen at 2 years. And so it was a self-limiting condition, but it took quite some time. Finally is off oxygen and when she was 8 years old, except rarely she needs nighttime oxygen when she develops respiratory infections. She also has intermittent systemic hypertension and recurrent warts. Anyway, so this was the CT scan of the child. You can see pretty severe interstitial lung disease. And this is the lung biopsy showing these infiltration by the macrophages and also fair amount of hypertrophy of the pulmonary arterial muscles. So nothing specific here, but something that So we enrolled this family, did exome sequencing, and found that the child had a mutation in a gene called ARIGAP42. But anyway, this is a new gene. Nobody knows what it does. And we did a lot of functional analysis, as shown here. We did some of the looking at how this variant affects the transcript in the patient, and then look at the expression levels using single cell data, and showing that this gene is highly expressed in early life, and then its expression goes down, at least in the mouse, and then also in the type of tissues, you can see it's highly expressed in the mesenchymal and epithelial cells, which fits with the type of phenotype this child had. We did some more analysis, including using the cells from the patient and the parents to show that the protein was deficient in the patient, as shown here on Western blot. And we measured ROA activity, again, very basic, but bottom line is that finding this variant and reaching to the final calling that this is indeed the cause of disease is a long journey that we have to undertake, and often it involves using cellular and mouse models for the disease. And we published this paper this year, and showing here that the smooth muscle cell gene, highly expressed in smooth muscle cell, or this gene is one of the new genes that we have found now that can explain the interstitial lung disease. We are still looking for more patients who have the mutation in this gene, but that hasn't happened yet. The other thing I told you about is that we are also reanalyzing exome sequencing data. So many of the families, despite exome sequencing, don't get a diagnosis. So this is where we try to use our own expertise to solve those cases. And this is what we do. We consent the family, get the raw data, and then we analyze it using our own pipeline. And this is an example of our pipeline, what we do. We get the patient information. We have a team of people who do the work and analyze the data using all these steps, and many genomic databases, and our own data is extensively used to come up with it's like finding a needle in a haystack, and often it takes a lot of time and efforts. So we had published a recent study where we reanalyzed 102 probands, and for 6 of them we could find a definitive cause for the disease, and another 18 we found a candidate gene, which means about a third of them we could find something that can explain the disease. And these were the 6 cases that we described in that paper, and just to show that this approach can help families to find the cause of disease in their child. And lastly, we are also working to support the development of personalized therapies. And this is an example where this child, her name is Mila, and we enrolled this family, and Dr. Tim Yu and her mom, and Dr. Yu, working with our team, developed a treatment that was unique for this child, and it worked for some time. Unfortunately, it was very late disease. Child was severely affected and was worsening pretty rapidly. It slowed down, but didn't slow down enough, or could not reverse the problems, and the child finally died, sadly. But it really made a difference in terms of our understanding and our potential for developing treatments against such genetic disorders. This paper was published in New England Journal of Medicine, describing that experience. So lastly, I want to talk about a little bit about our neonatal genomics program. So this is, as you know, genomics is a pretty vast field, but what we are trying to focus on is how we can implement rapid sequencing in our NICU and other NICUs, how we can continue to perform molecular autopsy, how we can continue to do data reanalysis, and integrate other sequencing technologies, including RNA-seq and genome sequencing, and many other technologies that we are interested in. And then functional analysis using cellular models or animal models, and then integration with the community NICUs that we are working on now. And then we are also building a NICU biorepository and building personalized therapies for our patients. And these are some of the members of the team. This we established in 2016, and I'm the director of the program, and we have several faculty who are all neonatologists, and they are all actively involved with their own expertise. For example, Dr. Sarah Morton, she's an expert in cardiovascular genetics. Monica Vorchik, she's an expert in outcome research for genetics. Amy O'Connell, she's interested in immunodeficiency. And Anna Duncan, who is interested in neurodevelopment and genetics of that. And then there are two fellows, Alyssa Degama, who's a second-year fellow, and she is working on epilepsy as a genetic condition, and Dr. Garcia, who is also interested in outcome research associated with genetic conditions. So I think neonatal genomics is a vast area of clinical application and translational research. And we are the first program in the country who are really focusing on this, applying genomic technologies in the NICU. And we have several exciting projects that are underway at this time. And today I didn't cover ethical, legal, and social implications because that's not a field of my interest, although we have some members of the team who are interested in it and are taking the lead. And this is my lab and the Manton Center, and these are some of my funding resources. I want to acknowledge the Because of Bella Foundation who have supported us, and then some of the NIH funding that has helped us to continue working on this. So with that, I want to end here and happy to take any questions.
Thank you, Pankaj, for the excellent talk. So rare disease itself is tough to diagnose. You are diagnosing and treating them, and you are leading in neonatal genomics worldwide, and especially in the US. And he has completed 25 years of passing DM. He is 6 months senior to me in PGI, and he has done a great job. And we are awestruck by your work and how much work, how much hard work and patience you need in diagnosing and treating such conditions. So thank you very much for sharing your experience. Thank you.
Yeah, thank you so much, Suresh. And I would say that it was such a pleasure to be here today. And Suresh, thank you so much for inviting me. And we go long time back, and we still have very fond memories of a time we spent at PGI. So we are connected by PGI, and just very happy to be here today. Thank you.
Thank you.
I must say we have a very good CME today. Two extremes where Naveen spoke about the basics of stops, how to take care of sick newborns, how to identify them. And other end, we have Dr. Pankaj, who spoke about the hi-fi excellent, very advanced knowledge about neonatal care. And I think the days are not far off where, in addition to matching the grahas for a married couple, we're going to do genome sequencing and see whether they're compatible or not. And we remember that newborn screening, which was very primitive long back when we were doing our PG in Gandhi, getting a TSH was a big effort. Now we have so much of advancement in identifying diseases by metabolic screening. And the next step is your genome sequencing of molecular biology, which is not far off. And definitely these things will help in a better newborn care. Thank you, Pankaj, for a very nice and very informative lecture.
Thank you so much. Thanks so much for inviting.
Jagdish here, Dr. Jagdish.
Dr. Pankaj, it was a very fascinating talk which you have given on genome sequencing and exome sequencing, and then biopsies, molecular biopsies, autopsies. And we are really fascinated by the work which you are doing. We wish that we were younger and then would get involved in these experiments which you are doing. I think you have also stressed the importance and the advantage of genomes sequencing over a routine newborn screening. So I think with time, I think you can help a lot of people in actually tailoring their mode of treatment and also elevate their suffering. So I think this is a great work which is being done by you. And it was a very lucid presentation of all the work which you have done. I compliment you for that. Wish you all the best in all your future endeavors. It was a pleasure listening to you. Thank you, Dr.
Thank you so much. Thank you, everyone, for listening and tolerating me for the last half hour. So thank you very much.
So it's very exciting, Pankaj. And now days will come where IAP, NNF, and even Government of India, Modi ji will call you to start genomics in India. Even in India, most of these things are available. Remember in 2019 when you came, we presented some genomic sequencing of a baby with hypotonia, where we diagnosed RGR1 gene sequencing in a child who has been given hypothermia in some center, but turned out to be a myopathy.
Yep, exactly. So I remember that was, you mentioned that case. And definitely India is, as you know, there are lots of recessive disorders in India, and many of them are still to be identified or discovered. So there is so much work that can be done. And I just want, one of my goals is to really excite the next generation of neonatologists and people to really look into this and think of this as a career move. Also, and how in the process help the families. So yeah.
So have a tie-up professionally and academically in helping our patients also. Whenever a possibility comes, try to develop a network of training our people as well as taking samples from our patients.
Yeah. Thank you, Suresh. Thank you.
Thank you. So thank you very much, Pankaj. Over to you, Dr. Surendranath Garu.
Really, it is a wonderful session. Thank you, Dr. Suresh, for organizing today's session. And in fact, the speakers, Dr. Naveen Jain and Pankaj Agarwal, they are wonderful, in fact. As Vasudev Murli told, that from the basics to the genomics, it's a wonderful journey today as far as neonatal care is concerned. Thank you, sir. Thank you very much. As Suresh told, that we are not far up, though we are still considerative about the developmental pediatrics for the neonatal care. At the same time, undiagnosed conditions can be diagnosed by the genomics.
Yeah.
Thank you very much. And I thank all the chairpersons, Dr. Vasudev Murli, who has readily accepted our invitation, and Dr. Jagdish Chandra sir, who is our mentor as far as NRP and neonatology is concerned in Telangana. Thank you, sir, for joining with us. And at last, I thank the DIAP hosts who have organized today's program, and Central IAP President Dr. Piyush Gupta, Bakul Parekh, and Basuraj for giving an opportunity for Telangana for DIAP programs. Thank you, sir. Thank you very much, sir.
Thank you very much. Thank you.